What are the protocols for getting a PAD patient's heart checked? Is it typical that the GP refers to the cardiologist and the cardiologist to the vascular surgeon, or does it go straight to, if they get diagnosed with PAD first, it goes to the vascular surgeon, and then how do they get to the cardiologist, or do they, for the most part, get to the cardiologist just for preventative measures?
Well, the good GPs will send them to the cardiologist at the same time that they send them to the vascular surgeon. And I've got quite a good group of GPs, certainly in my country practice where I work, who will do that because they know, I tell them all the time, once you've got PAD, you've got to make sure the coronary disease is sorted first. But I also do see a lot of patients who are referred with fairly late PAD, where, if they've got tissue loss, they can't wait. And so I'll take them in, I'll fix up their peripheral arterial disease, and at the same time, get a cardiologist to come and see them. Sometimes as an inpatient, or sometimes after I've done their PAD, I'll get them out, just literally just down the corridor. So we'll get them out to have a stress test, or a nuclear scan and an echo, and go from there. But certainly it's well, and in addition, I should say, we also will work up their PAD, right? So we don't just say, oh, okay, it's in your left leg. We'll do ultrasound scans, clinical assessments of the right leg, the carotids, the renals, the aorta, basically looking for all the places where they could have PAD and making sure it's sorted.
Oh, wow. So you do a full comprehensive approach, because that's not necessarily similar, in my experience in other areas. Sometimes they'll just do, you have pain in your legs, they'll do it, and they suspect that maybe it's in the thigh or down. They'll do it from the abdomen down. They won't go any higher. They won't check the renals. They won't check the inferior mesenterics. They won't check the subclavians. They won't check the carotids. Like, you have to push, you have to advocate to get these tests done. I mean, to even get a CT angiogram sometimes is a huge fight. And so it's nice to hear from your perspective that you're like, okay, we're going to do everything, at least get some sort of foundational look at whatever you got going on, things we might not even see yet, so we can get ahead of it, right?
Absolutely. So like, we all have vascular labs attached generally. You'll have a vascular lab attached to your clinical practice. So when I see a new patient with PAD, I want to know everything that I'm dealing with. So we get everything scanned. And if someone's got severe carotid disease, it's a marker of a higher risk for coronary disease. So it puts it into that patient's medical story, that the severity of PAD and therefore the risk. And so it might just tell the cardiologist, hey, even though that stress test is normal, maybe you should do a CTCA, or maybe you should do a coronary angio, because they've got fairly extensive PAD. So yeah, absolutely. I know my colleagues here do, but at other places, if patients aren't getting that full workup, they need to. Absolutely.
Yeah, for it. It's interesting because Bambi, who's watching on YouTube, we're streaming online across YouTube at youtube.com/The Way to My Heart, and then across our Facebook channels as well. And she's saying that, oh my gosh, I didn't know you could have the plaque buildup elsewhere. Yeah, you can have it right in your subclavian. You can have it in your gut. You can have it in your neck. So it's the human superhighway, right? I mean,
yeah.
If you have plaque one place, it's likely you have it in another, right?
Absolutely. And I think it's very important to detect it, to be aware what's there, so that it can be managed. Yeah, I think, if patients are seeing their vascular specialist and that's not happening, then they need to demand it.